Say we legalize all drugs. By the currently illicit drug. And then I thought,
Good afternoon, and welcome to the Cato Institute. This week, the Cato Institute releases an exciting new book, the Cato Institute's latest book on health policy, Your Body, Your Healthcare, by Cato Institute Senior Fellow Dr. Jeffrey Singer. The message of this book, if I can try to encapsulate it in one sentence, is no matter what issues arise in health policy or drug policy, whether it is what clinician you consult, what medical facility you use, what medicines go into your body, or even whether to ingest risky things, it's your body. Therefore, the choice should be yours. My name is Michael Cannon. I'm the Director of Health Policy Studies here at the Cato Institute. And joining me to discuss your body, your health care today are the author, Dr. Jeffrey A. Singer, and Duke University Professor Nita Farahani. Our run of show today will look like this. I'll introduce Dr. Singer and Professor Farahani by way of a brief conversation with each. Dr. Singer will tell us about his new book, Your Body, Your Healthcare. Professor Farahani will share with us her thoughts and comments about the book, and then we will open the floor to questions. Now, our live audience will be able to ask questions of our panelists directly. I will pose appropriate questions that our online audience submits through the appropriate channels. You may join the conversation and submit questions directly on the event webpage through Facebook, YouTube, and on Twitter/X. And I will also have a few questions of my own. Then after the question and answer period, our live audience will rush to purchase copies of Your Body, Your Health Care in the Cato Institute's Winter Garden. And our online audience will rush to purchase copies at Amazon.com or cato.org/books. Our live audience will then join us upstairs here at the Cato Institute, up the spiral staircase for a luncheon in the Cato Institute's Conference Center. So with that, I want to turn to you, Jeff. Dr. Singer, you are a practicing surgeon in Phoenix, Arizona. And you went to med school and did your residency where?
In New York.
In New York?
New York City.
that New York.
Where I come from, New York means New York City.
Yes, but which school with hospitals?
I went to New York Medical College. That's where I got my MD. I went to undergraduate school at Brooklyn College. And I did my residency in general surgery at was then called the Maricopa County General Hospital. Now it's called Maricopa Medical Center in Phoenix. Then I became board certified as a general surgeon. I've been in practice since 1981.
And so you went from Brooklyn and New York City to Arizona. And how long have you been in Arizona?
I've been in Arizona since 1976.
How was that transition going from Brooklyn to Phoenix?
It was a little bit of trauma. I was the only Easterner in the residency program. And so my colleagues, everybody was very nice, but they would make fun of my accent and also there's a much smaller bubble in the New Yorkers kind of stay closer to people. And so when we'd be, conferring at the bedside, sometimes one of my colleagues would turn around and say, could you back away a little bit? Because, people...
More close talking. So you're also a Cato Institute Senior Fellow, and that has been, I was here, but you're going to have to remind me of the year.
Since 2017.
2017. But we met long before that because you were a Cato Institute supporter.
And I was an adjunct scholar also.
And who made the leap from supporter to scholar. Now, I was looking at your bio page on the Cato website, and since joining us in 2017, you have written studies. These are not op-eds or blog posts. These are studies about abuse-deterrent opioids, harm reduction with regard to the drug war, clinician licensing, government-imposed prescription requirements, harm reduction with regard to COVID-19, drug paraphernalia laws, psychologists prescribing medications, cops practicing medicine, overdose prevention centers, assistant physicians, a new version of the Hippocratic Oath, what you call a Hippocratic Oath for a Free Society, access to methadone treatment, pharmacists prescribing medications, regulation of lactation support professionals, and a couple more papers that are still in the pipeline. All of this while still practicing surgery.
Usually not at the same time.
Usually not at the same time. And on top of all of that, you wrote a book. On top of all of that, why? Tell me about.
Well, actually, I'm going to give you credit because you encouraged me to. But what I basically saw was, and you helped me see it, was a kind of an overarching principle linking together all of these other policy areas that you mentioned that I worked in. And that was the principle that we need to approach things from a presumption of liberty or presumption of autonomy. In other words, we as adults start with, as autonomous adults, start with liberty. And so you need to look at all of the government interventions in the patient-doctor relationship and in healthcare in general as infringements on our autonomy, or possible infringements depending on what the interventions are. And so based on that, I was able to link together the various papers I'd done into one book where it all flows from issue to issue, and put it all together based on that.
Great. We'll be hearing more from you about that in a moment. For now, Professor Farahani, education, AB in genetics, cell and developmental biology, ALM in biology, JD in law, MA in philosophy, PhD in philosophy. I know what some of those abbreviations or acronyms are, not all of them. You are now at the Duke University School of Law, where you're the Robinson O. Everett Distinguished Professor of Law and Philosophy. You're the founding director of the Duke Science and Society, faculty chair of the Duke Master's Program in Bioethics and Science, principal investigator at something called the SLAP Lab. Maybe you can. Science, Law, and Policy Lab, and you teach courses in criminal law, FDA law and policy, AI law and policy, a course on how to write amicus briefs, I presume is what that is, and then the Forensic Science Colloquium. And for about 7 years, you were on the Presidential Commission for the Study of Bioethical Issues. And your latest book is The Battle for Your Brain, Defending Your Right to Think Freely in the Age of Neurotechnology. I have to cut it off there because your bio and your CV, well, they were longer than a lot of the reading lists on some of the law courses that I took. So with that, I want to thank you both for coming here, especially Dr. Farahani, and turn it over to Jeff so that you can tell us about the book.
Okay, so the main point of my book, I opened the book by discussing the fact that we doctors nowadays, from the first day of medical school, have it sort of drilled into us and marinate in an ethics that says you need to respect the patient's autonomy, that you cannot perform a test, a procedure, or a treatment on the patient without getting their informed consent, which involves also letting them know the risks, the alternatives, and the need for it, the benefits of what you're recommending. And so, but this is actually a relatively modern development in the medical profession. It wasn't that long ago that doctors were extremely paternalistic. Some of us are still guilty of being unethical, in my opinion, but it wasn't that long ago where doctors believed that they could withhold information if it wasn't really, it was better for the patient not to know that because they may not participate in the treatment that the doctor thought they needed, had they had that information, or they would just do whatever they thought they had to do. In fact, I point out in the introduction of my book, there was one of the more famous cases that kind of started the ball rolling in the direction of current-day medical ethics was a case of Mary Schlowendorf, who in 1908 at New York Hospital, her in those days, of course, we didn't have MRIs and CT scans, so it was very common to do what was called an examination under anesthesia, where the person's muscles are all relaxed and you can appreciate the internal organs more easily. And so the doctor suspected that she had a uterine tumor. He wanted to do an exam under anesthesia. She said, under one condition, that you don't do anything except examine me, and then afterwards we'll discuss what you found, discuss your recommendations, and I'll decide what we're going to do. So the doctor performed the exam, palpated a uterine tumor, turned out to be a fibroid tumor, proceeded to do a hysterectomy, and then Ms. Schlowendorf had a whole bunch of complications afterwards. She eventually survived, but she was understandably, she had some disabilities as a result, and she was understandably very upset. It went to court. She won on the first round. It got appealed, and there was a very famous opinion uttered by then New York Appeals Court Judge Benjamin Cardozo, who later became a Supreme Court Justice, that I'm paraphrasing now because the exact wording is in the book and I don't have it committed to memory, but basically that every adult of sound mind is an autonomous individual, and to do something to them without their consent constitutes an assault. That didn't change things, but that was like one of the more outspoken events. There were several other lawsuits, similar kind of situations around that same era, but it was really throughout most of the 20th century. You know, we had the horrible Tuskegee experiment where patients were not even being told there was now a cure for syphilis because the doctors conducting the experiment wanted to see just how the disease, untreated disease, what the course looks like. So they had this information withheld from them. Of course, we had live human experiments during World War II and the Nuremberg war crime trials. We had, forced sterilization. All these kind of things were commonplace. And even as late as the 1970s, a survey done in the Journal of Oncology found that I think it was 60% of cancer specialists admitted that they withhold certain information about their patients, the severity of their diagnosis and the prognosis, in the interest of getting the patient to cooperate with what they think they need as treatment. So this is a relatively recent development. And then from there, I point out, well, now that our medical profession seems to have it right and respect autonomy, that's not the case when it comes to the government. In so many different aspects of healthcare, the government tells us, for example, and on different levels, on federal level, on state, local level, the government tells us, for example, what kind of people we are going to be able to get advice from. It even stipulates what degree of education they must have, and whether or not we could ask certain people to treat us for our problem. It tells us what kind of medications we're going to be allowed to take to treat our condition, and sometimes depriving us of access to medications that are available in other parts of the world. And sometimes when it tells us what kind of medications we're going to be allowed to take, it says, but we first have to get a permission slip from another autonomous adult like ourselves called a licensed healthcare practitioner, or basically a government gatekeeper in my perception, before we'll be able to access that medication. It also tells us what kind of products we can consume, which is a form of self-medication in many cases, but these are products that we want to put into our own bodies for whatever reason we may have, because the government decides that these products are not good for us and we should not be consuming them, even if we're not hurting anyone else. So basically, as I close in the introduction, in summary, the government does to us adults every day what Mary Schloendorff's doctor did to her. And so then I use that as the jumping off point, and I go over these different areas that I just mentioned, which are areas that I've done policy analysis research in, and I take them one by one as examples where the government is infringing on our autonomy. I also provide suggestions as to how to get back to a situation where our autonomy is put first. My approach, basically that's the way we approach everything here at Cato. We start off with the ideal solution from our perspective, but we're also realists. We know the world we're in. So after proposing what would be the ideal solution, then we point out if that's not politically feasible at this point in time, a second best choice that would move in that direction would be this particular choice, and the third best choice would be this. And that's the way I approach all of these different issues in the book.
Okay, thank you. Professor Farahani?
Thank you. So first, an honor to be here in conversation with you, and an honor to be here with all of you. So thank you for the invitation and for the opportunity to get to read the book early. I should start with just my priors, which is as a person who's incredibly passionate about the concept of autonomy, of individual liberty, of free markets, and minimal state interference, I found myself in heated agreement for a lot of what I read in this book. But that would not make for a particularly interesting conversation if I simply said, I agree, and moved on. Is it not working? Okay. All right. Well, let's try that again. I just said a lot of things that were brilliant, and you missed them all, and so now I'm done. No, I'm
Sorry.
kidding. What I was saying is, there's much to like about this book, and I found myself in heated agreement of a lot of what was there. But again, to simply say to all of you, I agree, would not be a particularly satisfying conversation. And so what I want to offer are perhaps a few more nuanced critiques of what are sometimes presented as more sweeping anti-regulatory proposals advanced by Dr. Singer in the book, who urges pulling back on licensing requirements, the FDA, certificates of need, which I thought was a really particularly fascinating chapter in the book, and I learned a lot from it, prescription drug controls, the war on drugs, and even concerns about social media constructs, to adopt what is really a more like wholesale free market approach for everything from psilocybin to methamphetamines. And I want to say I really respect the boldness of this book, but I want to see if a more tailored approach might be more autonomy enhancing, where we share a common goal, and the question is, how do we get there? And so why don't we start with the core libertarian principle around fraud prevention? And so this is common ground, right? So fraud and coercion violate the voluntary nature of a transaction. And libertarians widely agree that one legitimate role for the government, maybe the only role, is to safeguard people from misrepresentation or from hidden harm. And here's the problem. If we strip away every licensing requirement or every safety standard, we rely purely on buyer beware or third-party certifications. And so in principle, I agree that certification agencies could step in. In practice, real-time knowledge for patients or consumers, especially in complex realms like healthcare, might be too slow to filter out malicious or even incompetent actors. So the question is, does a minimal government standard, which doesn't have to be oppressive or paternalistic, serve to protect the voluntary nature of transactions by ensuring that the buyer truly knows what they're getting? Which brings me to the second question. So you touch on externalities in the book, but don't dive in deeply to them. And I find often that this is one of the bigger pushbacks to some of my arguments. Like in my book, The Battle for Your Brain, I make a strong claim, contrary, surprisingly, to what most bioethicists argue, that we ought to allow cognitive enhancements pretty much unfettered access to it in society. And the argument people like to make back is the externalities, the race to the top, the race to the bottom, none of which I find particularly compelling. But I think we all agree that your right to swing your fist ends where my nose begins, right? So in healthcare, and especially in the drug market, one person's private choices can create spillover costs on everyone else. And so if you consider, for example, an unregulated provider who botches surgeries, or prescribes substandard medication, this can lead to more emergency admissions, higher insurance premiums across the board, and even public health crises. Which isn't to say that we should ban all risk-taking, but it means that we can't ignore legitimate externalities. And so if excessive freedoms in the medical or drug market leads to unaccounted to harms for third parties, it might undermine the very premise of consensual transactions. The third big concern that I think we have to grapple with is the question of information asymmetries. And here, I think throughout the book, you presume, and I often do too, that most patients can accurately judge the competence of surgeons or the purity of their medications, and that reputational feedback will be either fast enough to drive out bad actors. And I think it's fair to place faith in competitive markets, but we also have to be honest about the complexity of healthcare. So a person might not know how to evaluate whether a proposed treatment is safe, effective, or frankly dangerous. And while multiple private certifiers or rating systems could emerge, that could also lead to confusion and dilution of accountability, which certifications are legitimate, which is a marketing gimmick. So the question is there something like a minimal licensing or accreditation standard backed by a limited government body that could promote a functional market by preventing a race to the bottom? Which brings us to the FDA debate. It's hard not to agree, but I have to be a little contrarian here. And so the question for me is, one of the most compelling articles that I have read that I teach in my FDA law and policy class is the take on the FDA that it has a powerful information forcing function. And a powerful information forcing function that if we limited it to that, ends up being more effective than any third-party certifier or third-party or market mechanism could achieve. And if it were to focus solely on safety, and by here I mean safety not in the way that it has taken permissive extra steps toward informational safety, trying to judge whether people are psychologically harmed by information, but truly safety in terms of like the little mag kind of safety, could that be an effective minimal role for the FDA rather than a pullback of it altogether? Which then brings us to total deregulation of drugs and freedom versus addiction. And here I want to bundle this together with social media. I think that Dr. Singer lands on something that's incredibly important for us to grapple with in the modern era, which is the temptation to label every dependence or every use of a drug or device as addiction rather than, for example, a coevolution or a use of. I think you could push even harder on the nicotine example. There's so many examples of how nicotine as a patch, for example, has cognitive enhancing effects when it isn't inhaled, that it may not actually have any of the negative effects that are associated with vaping or even, what is it called, the patch that you talked about that's put inside the mouth?
Yeah.
That thing.
Ouch.
And, you know, to really say, like, what does the language we're using do and justify with respect to government stepping in? Now, I think that's a compelling argument and one that you should lean into even more heavily, and with the nicotine example, lean into even more heavily to show all of the positive use cases from a cognitive enhancement perspective and the problematic language of it. Social media is where we might diverge. And here I will really conclude my kind of beginning remarks on this, which is to say, I'm a little bit more torn than you are on social media. On the one hand, I fundamentally agree that we should worry deeply about government regulations that infringe on free speech. On the other hand, social media may be different in kind than the healthcare industry. And the way it may be different in kind is that many social media constructs are designed to attack the core of cognitive liberty itself, that is our capacity to think freely, by trying to interfere with our interoceptive capabilities, our critical thinking skills, and our capacity to relate to one another. If we think about cognitive liberty as foundational, the kind of scaffolding of thought itself, it would come before even free speech. And to the extent that social media constructs are designed to attack at that core, here there may be a role for governments not to try to limit speech or for content moderation, but to address the asymmetry in power that algorithms are playing in trying to attack our capacity to think freely at all. And so I would just invite you to potentially separate your body, your health from a healthcare perspective from the social media kinds of constructs you have in there. I'm glad to hear that you, despite the incredibly bold language throughout the book, recognize the need for incremental change over time. I think that's the most likely way that we can achieve a lot of the bold recommendations in your book. Thanks.
Okay, thank you, Professor. Jeff, before you respond to Professor Farahani, one question for you. What is the one takeaway you want people to have from this book?
Well, I think, first of all, I wrote the book targeted towards a general, a well-educated general audience, not necessarily an audience that's very familiar with healthcare policy. So, I'm assuming that a lot of people are getting exposed to some of these ideas and proposals for the first time, and it may come to some people almost, like as a bucket of cold water dropped on their head. So, if there's one thing that people are left with after reading this book, I would hope it would be that when we hear discussions about what the government should or should not do regarding health policy, they suddenly become much more aware and sensitive to the matter of adult autonomy, so that when they're hearing, let's say, should the FDA approve this drug, they realize, well, actually, I have a right to that, to access that drug. It's really, the FDA is basically getting out of my way of using that drug. It's really not, when they're so-called approving it. If I can get people just to kind of realize that there's a presumption of autonomy, and they could reframe a lot of these debates that are in the public square along those lines, then as far as I'm concerned, I've succeeded. That's really all I could really hope for.
And any response to Professor Farahani's comments?
Oh, well, there's a lot of them now, so it's, I got to keep track. We were sort of taking notes, but as far as the licensing is concerned with and information asymmetry, we have that now. I mean, I use the example in my book. I'm a surgeon. I've been practicing over 40 years, and I have a license to practice medicine. So if I wanted to tomorrow, I actually, in any state, by the way, I could just decide, I think I want to switch fields now and be a psychiatrist. And I could do that. I have a license to practice medicine that comes under that umbrella. And the only thing that actually protects the public is the fact that no hospital is going to allow me on their staff without credentialing me and being satisfied that because they got their reputation and liability to be concerned about. No health plan would want to list me on their panel for the same reasons. And in fact, my malpractice insurance carrier probably would tell me that it's not going to cover me. So these are all private civil society entities that are actually acting in their own self-interest to protect the public. In fact, historically, it wasn't that lawmakers got together and said, look, these doctors are out of control, we got to license them. It was the medical association that was primarily created to get licensing in the mid-1800s that went to state legislatures and said, you need to license us. In almost every instance of licensing, whether it's a professional license or an occupational license, it's usually the people in the field who are requesting the licensing to, quote unquote, protect the public from people who are not them. And so the licensing really it just protects the incumbents. There are plenty of intermediaries that protect the actual consumer. In the case of healthcare, you have the different specialty boards, and which, by the way, could, if there was no government monopoly like the FDA in the middle, I could envision, for example, the American College of Cardiology getting into vetting different cardiology medications and signing off on them regarding safety and efficacy. Before the FDA got into the whole safety and efficacy business, the American Medical Association, they're not all bad, had the Council on Pharmacy and Chemistry that was vetting a lot of drugs, and companies that didn't want to cooperate were deemed unethical. So it's actually nowadays even easier with the access to information using the internet and AI platforms. It's easier for people to do their due diligence than it was 50 years ago. So I don't think licensing is also usually captured by the profession or occupation that has gotten licensed, and ends up. There are numerous instances of, for example, physicians in different parts of the country who've actually been accused of and sometimes convicted of sexual assault, who don't lose their licenses. I know of colleagues in my city who have had so many malpractice suits that they can't get malpractice insurance coverage, but they still have their license. So the license isn't really what's doing it.
About the physician profession, you are a doctor. What has been the reception of other physicians to this book and the ideas that you present in this book that you presented over the years? Well,
this book, it just came out, so I don't know how many of my colleagues have had a chance to look at it yet, but I can tell you the issues that I discuss in this book, I've discussed with my colleagues for many years. And most of the time when I suggest that we shouldn't have licensing, they look at me like I have two heads. And I could forgive that because, we've kind of grown up in an environment we don't know any other way. So I totally understand that. In fact, when I began thinking about that many more years ago, I originally kind of felt, am I crazy thinking this way? So I get that. Doctors are obviously very smart, and they have very jam-packed days under pressure. They don't necessarily think about these issues very much. They tend to just concentrate on, on their job. So a lot of the colleagues I've run into when I discuss some of these issues with them, I'm not necessarily rebuffed, but it's almost like, this is the first time I got them to even think about something like this. Then again, there are many doctors, as you know, who are in the policy world too, so they think about it.
I think one of the examples in the book, or one of the policies that you talk about, is scope of practice. When the government licenses clinicians, it provides not just the license saying you can practice medicine, but here it delineates here are the services that you can provide. And doctors have a plenary scope of practice, but what they call mid-level clinicians, people who receive less training than doctors have, they get a scope of practice that the government limits. And one of those types of mid-level clinician is the category of certified registered nurse anesthetist. And that has come up in your practice, I believe, because you're a surgeon, you work with anesthesiologists and CRNAs. And can you describe what the reception to your work has been?
Well,
in that
actually,
area?
that was a almost frightening experience. So CRNAs, Certified Registered Nurse Anesthetists, these are advanced practice nurses. Actually, they've been around since the 1800s. I think the first one, if I remember correctly from my book, was at the Mayo Clinic. And the original Mayo Clinic years ago. They are professionals who are trained to provide anesthesia. In my residency program at the county hospital, most of the people gave anesthesia to my patients. And I can remember these really intense situations at 2 o'clock in the morning with a gunshot wound to the abdomen, and I had a nurse anesthetist at the table. And they're in the military, they've been around a long time. In most states, they are not allowed to practice independently. They have to be either employed by a physician anesthesiologist, or have some sort of contractual agreement where they are technically agreeing to be supervised by the physician anesthesiologist, and therefore it's basically, they're giving them a piece of the action, sort of. During the COVID pandemic, then Governor Ducey of Arizona, with the cooperation of the Arizona Anesthesiology Association, I don't want to get into the weeds here, but was able to basically give CRNAs the opportunity to practice independent of physicians. And the Anesthesiology Association sent out a few weeks afterwards an email to all surgeons in the state, because we're their customers, saying, when we agreed to this, we thought it was just for the pandemic. We didn't realize this is permanent. This is not safe for patients. We need to do something about this. Please sign this petition. So that's made me aware that this was an issue. I wasn't even actually aware that this happened. So I said, okay, I'm going to write an op-ed, which got into the Arizona Republic, the biggest newspaper in the state, basically saying, I've been working with nurse anesthetists for years. I don't see what the problem is. Of course, the anesthesiologist said they can get in over their heads sometimes. And as a general surgeon, sometimes I get in over my head. Sometimes I'll see a patient with a complicated surgical problem that I haven't seen in years, and I'm ethically bound to tell the patient, I know someone who got a lot more experience with this than I do. Let me refer you to that person. Why would a CRNA, who's also professional, not do the same thing? So that caught so much wrath. I was getting I've been in practice a long time, so most of the anesthesiologists in the state know my cell phone number, and they were texting me really nasty comments and pulling some real sarcastic things, like when I would show up to do outpatient surgery. Normally, the anesthesiologist gets there ahead of you to interview the patient and then get the room set up before, and that's when then the surgeon shows up to talk to the patient. So on more than one occasion, I'd show up, and the anesthesiologist saw that I showed up and would say to the patient, excuse me, and pull me aside and say, are you comfortable with me doing anesthesia on the patient? After all, I'm not a nurse. And I would make the comeback of, oh, Steve, I've worked with you for years, you could do it. That's the kind of answer we get from me. Now, I was in the green room, I was talking to Nita about this. It's kind of helpful on this stage of my medical career too. So, I'd like to think I know I was always principled, but probably at an earlier phase in my career when I was working on building a practice, I was a little more, let's say, restrained and circumspect in my expressing my viewpoints. Whereas now I feel kind of liberated. So I'm probably, I like to say I'm bulletproof.
Professor Farahani, want to jump in anytime, please do. Otherwise, and interrupt, please do, because I've got a whole raft of questions, and we're getting questions from our online audience. Thank you very much. I'll go to one of those now from Anonymous, who writes, there's a large movement of women who say they felt pressured into giving birth via C-section by their providers, and who have organized into advocacy groups such as the International Cesarean Awareness Network. Can you comment more on the state of mothers' medical freedom during childbirth?
I'm not an expert on that. I do know that there, in many cases, concerns about liability lawsuits led many OBGYNs to, at one point, be overly liberal in recommending cesarean sections rather than risk traumatic natural birth injury. Although my understanding is that's sort of that trend has changed now, and we're getting back to, as women are getting more assertive, we're getting back to not resorting to C-sections, including, it was at one point thought that once you have a C-section, you have to get a C-section every time thereafter. But now we're seeing many cases of women who deliver vaginally without, even though they've had a prior C-section. So I think the pendulum has shifted back on that, maybe largely due to activist groups like this person who asked the question. Do you have it?
Sir?
Yeah, I mean, I think that's right. I think especially older mothers are feeling a lot of the pressure for C-sections, where, this gets at a kind of a subtler point in the book, I think, and more generally, and one that I confront in The Battle for Your Brain, which is there's overt paternalism, and then there is subtler forms of paternalism that exist within the healthcare industry. And part of that is, kind of the omission. So how much do doctors actually choose to share with their patients? There's informed consent, and then there's fully informed consent. And traditionally, a lot of, well before kind of norms of informed consent, and even post norms of informed consent, most physicians feel like their job is to filter information that they share with patients, to decide, what to share with them and what not to share with them in terms of interpretation. And in childcare, this has been the case quite a bit as well, which is, it's subtle, which is, here are the risks of somebody who goes to 39 weeks versus 40 weeks and what the weight of the evidence shows for a particular age group. And here's why a scheduled C-section is more convenient for the physician. They're not going to tell the patient, actually, I'm not on the weekend, and I'd like to make sure that you deliver when it's not the middle of the night for me, and so it's more convenient for me, right? So it's this question of paternalism by omission and how much information they're actually sharing with patients. And I think that's one of the things that is not as overtly grappled with in your book, but becomes a problem for autonomy is some good moves have happened, which is patients pushing back and having things like patient advocacy groups to say, wait, why do I need to have a C-section? And is that really in my best interest or in the best interest of the child? Is it in the best interest of the mother, or is it in the best interest of the physician and their schedule so that, they're not delivering in the middle of the night? And then it's this question of, when test results started being automatically released to patients, in many ways, I think that was a wonderful move. Physicians didn't like it because it meant that patients were getting direct access to a lot of medical tests. They were having questions about those medical tests and the results, where physicians might have chosen not to share all of those results because they think that individuals don't have the capacity to understand or contextualize that information. All of that, to me, gets at fundamental concepts of patient autonomy, of giving people full access to their medical records, full access to information so that they can make more fully informed choices. But until we combat these subtler forms of disclosure, where it's omissions to the patient to be able to make fully informed choices, there's still this significant asymmetry between physicians and patients.
If I could just respond to that, I agree with you completely. I didn't spend as much time perhaps as I should have on these things because my focus was on how the government interferes with autonomy. I was using the physician ethics as an illustration and a jumping off point. But, like I mentioned a few minutes ago, physicians are humans. So, in fact, since I've written the book, I find myself when I'm interacting with my patients, a little voice in the back of my head is saying, are you telling them everything, or are you keeping something from them? Because, I have to, obviously, I don't want to be a hypocrite. I just finished writing about this. But there's a tendency, I think that's just human nature. There's going to be a tendency to try to kind of minimize certain things and maximize other things. And probably that's not just limited to the health field. That's probably limited to every service. As far as the testing is concerned, I understand there's still just a handful of states where it's hard to get your own medical test. Arizona, where I practice, you could go into any Quest or LabCorp and just get a test. And I remember when the legislature was considering that bill, I was at the time I belonged to the State Medical Association, and I was the kind of the iconoclast on the Committee on Legislative Affairs, which would instruct our lobbyists what position to take. And there was a debate, should the Medical Association be for or against the bill? And some of it actually supported it, but at the end of the day, but there were some members who said, well, somebody's going to get some test, and they're going to frighten themselves, they're not going to know how to interpret the data. And what I said was, well, they could always call you, make an appointment, and ask you what you think of the data. Nobody's preventing that from happening. So, and I'm pleased that the Medical Association in my state they ended up endorsing it.
Well, that circles back to this information asymmetry question, which I want to press you a little bit on the FDA. So I mentioned this article. I wish I remember who wrote the article, but it's called something like the information forcing function of the FDA, and it gets into the details about why many, like pharmaceutical companies, for example, would have no incentives with marketplace fully rather than with FDA to undertake some of the trials that they take, but certainly to report both failures in clinical trials with respect to drugs and other information that comes up through the clinical trial process. Now, I think that the clinical trial process is incredibly long. It's too cumbersome. It leads to less rather than more innovation in many ways that are problematic. I think 21st Century Cures helps to address some of those concerns by having things like biomarkers serve as endpoints in clinical trials. But I wonder what you think about this idea of government in a minimal function being autonomy enhancing when it serves in an information producing or information forcing function, right? So if the FDA was like, you have to, submit information in a following standardized and easy to access way for patients in order to market. Maybe they wouldn't even have an approval process, right? But it would simply be in order to market with your pre-market notification, you have to file the following information for public accessibility. So there'd be a credential, everyone would know if you want to learn about a drug, you turn to the FDA, that's where the repository of information is. What about an information forcing
So
function?
even if the FDA doesn't agree with the drug company's assessment of the data, the FDA will lift that barrier to entry. The drug company can take that drug to market.
Well, I'm not proposing this. I'm playing with the idea, right? Which is to say, as a thought experiment, what if the FDA's role is an information forcing one, which is you cannot market your drug until you have provided information into this marketplace, right?
Because right now they lift the barrier once you've provided the information
And
they're happy with the information.
Yes, exactly.
And that's the leverage that the FDA uses. Okay,
Yep.
sorry.
Okay, well, first of all, if the FDA were to be reduced to that function, I would not fight that. That would be a great improvement over what we have right now.
No, but I don't even want you to do it as an improvement, right? Which is to ask straight up, because you would probably then go one step further and say, go ahead and eliminate them. And I want you to play with this world in which we're building it anew and saying, is there a role where government serves an information forcing function that is autonomy enhancing rather than autonomy restricting?
The problem I have is that when it's the government, it's a monopoly. And also, when it has the imprimatur of government, even if it takes on sort of a different weight. So even when it comes to, for example, I'm not trying to get off the subject, but when you have the CDC issuing guidelines on how to treat pain, for example, and they stress this is just a recommendation, nobody's required to do this, it tends to be adopted as, well, this is what the CDC says, so how can we go against that? And it also gets used in civil tort cases. So this function can easily be met by the private sector. In fact, the AMA was doing a lot of this before. I think it was 1955 when they shut down the Council on Pharmacy and Chemistry. They were a repository, and they still collect information on adverse events with drugs.
Right, but
So-
the difference between government in this function versus the AMA or others, first of all, you might have many that crop up, and it's difficult for people to be able to sort between them. But the second is the failure that this particular article was pointing out, and the restriction that I'm putting on this, is that in order to market it, rather than being treated as mislabeled, and you cannot market your drug until you have actually done this, is that it is a forcing function. With the AMA, there's no forcing pre-market function of actually publishing information. Consumers don't have one source of information that they can sort between. It's not standardized. It doesn't require that it serve in any way that's actually consumer friendly and accessible. And the AMA doesn't have the power over drugs, or any other organization over drugs, to actually have that same forcing function of information. And just as a kind of compare, the supplements industry, which is almost entirely unregulated, and there is almost no third-party certification that actually can test and certify the purity of drugs or anything else. I subscribe to something called consumerlabs.org, which is an independent third-party testing company that does do testing of supplements. And so before I take any supplements, I always go there to check it. But that's it. That's the only one that I'm aware of that does any kind of rigorous testing of supplements, even though many of them have huge and disproportionate amounts of unsafe additives to them that can be problematic.
Well, first of all, people tend to view supplements differently than medications. So there's probably less of a market demand for information than it would be with actual, what people consider a different category of pharmaceuticals. But I think that as long as there's a market for this information, just like when you buy a house or a car or any important object, you want information, and there would be the development of different sources of this information had they not been preempted by the FDA.
But from a harm prevention perspective, wouldn't you want that information before these kinds of drugs were on the market? Which is like, if suppose it's a drug that's taken during pregnancy, and it's the thalidomide kind of story, or some other drug which turns out to have a lot of different side effects or problems during pregnancy, you don't find out about the side effects until after the fact, and after the drug has been marketed, and afterwards there is an information clearing system. I'm proposing a alternative, which is FDA, and this thought experiment, the reason I'm pushing on it is to really see, is the concern the current function that the government is serving, which is restrictive of autonomy, and can we imagine a different way in which government can serve an important information forcing function to enable consumers to have greater autonomy in healthcare decision making?
It's interesting you say that, because when the Food, Drug, and Cosmetic Act was passed in 1938, one of the key sponsors used that argument, which got us where we are today ultimately, which was nothing is here in this act is intended to infringe on patient autonomy. It's just to make patients' autonomy safer by clearing these drugs as safe. So again, I think there's the whole implementation question, which is a separate issue. So that if all of a sudden everyone agrees it's time to get rid of the FDA, how do you get from what we have now to a situation where there are a lot of ways people get the information they need? And I haven't thought that through yet. There might be some sort of transition period.
Well, let's take it with social media. So social media has lots of addictive constructs that are built into their platforms. That's true in non-social media platforms as well, but a lot of digital platforms have built-in constructs that have been well studied and researched to show how to bypass conscious decision-making by individuals and put them into a more automaton state. Suppose before being able to market and sell a product like a social media platform, there was an information forcing function that the government said you have to simply put up the data about what you know about how these constructs work on the human brain and autonomy. That's it. You can market it once you do it. Like, we're not going to restrict you from doing it. You just have to publish the data so that people can make free and autonomous choices, understanding and reducing the informational asymmetry that exists between the companies and all of the data that they're sitting on about how these platforms impact our brain and mental experiences and self-determination and individual autonomy. So that's it. Like, you just have to, it's an information forcing, like, you get your license to market as soon as you just simply publish all the information.
Yeah, I haven't had a chance to think about this, but my immediate reaction is that I'm a little uncomfortable with having it in the hands of a government monopoly, and also where it can go from there. The natural tendency is for these things to grow. So I would rather see private, spontaneous alternatives develop in the marketplace.
I want to encourage everyone in our live audience here to begin formulating your questions. We'll be turning to you in a moment, and maybe a couple more from our online audience. I wanted to ask you, Jeff, when I look at your book and the ideas in it, I think, the political right will probably like a lot of the ideas, like reducing regulatory barriers to new drugs, opposing mandates, repealing certificate of need barriers to entry for hospitals and other medical facilities. But they might not like your ideas when it comes to things like legalizing opioids or removing legal barriers to drug war harm reduction strategies like overdose prevention centers or needle exchange programs. I know in my career, I've met a lot of doctors who call themselves conservatives, limited government conservatives, who still say they don't like the idea of removing government barriers to nurse practitioners or CRNAs or pharmacists or even new med school graduates, doctors performing more services. And also, they might not like the idea, the right might not like the idea of eliminating regulatory barriers in the form of prescription requirements to birth control. And we can maybe say the reverse about the political left. They're going to like some of the ideas in your book. They're not. How do the political right and the political left respond to the ideas in your book? And are those responses sort of changing with recent changes in the Republican and Democratic parties?
Some things are changing. I've noticed in recent years, and it's not just with respect to healthcare, licensing in general. We're seeing a lot of people on the political left who like the idea of removing licensing barriers and are very open to expanding scope of practice of different healthcare practitioners, which used to be a position you would associate with the political right. But in my opinion, of course, only libertarians have the consistent viewpoints. So therefore, you're going to see on both the right and the left inconsistencies. So like you were mentioning, Michael, on the one hand, you want the government not telling you what medication you could take, except when it comes to certain drugs. In fact, the chapter in which I deal with that, I put the word "some" in parentheses. It's not the war on drugs; it's really the war on some drugs. So, as far as a lot of people on the political right are concerned, that if I want to alter my consciousness and become maybe even cognitively impaired in private for a little while, that's fine. Just make sure it's using alcohol, not cannabis or an opioid or something like that. So we see these inconsistencies, but we're also seeing a lot of reshuffling too. I think we're right now living through a sort of a realignment, and I think the realignment might be more along the lines of authoritarianism versus liberalism. That's the way things are sort of aligning right now.
It's interesting. It's such a nice question about the book because a few years ago, Jonathan Marino wrote a book called The Body Politic. And it really got into this idea that the traditional way that people align, right or left, isn't the case when it comes to issues of bioethics that you really grapple with in the book. And that you see odd bedfellows together aligning on different issues. And I think that's right for this book as well, which is, I think there's something for everyone in this book. You'll find people on the left finding some things resonate very deeply. You'll find some things on the right where people find things that resonate really deeply. And then you'll find some things on both sides that don't resonate at all. And I think that's what makes a great book, is one that actually, ignites conversation across the political spectrum. And doesn't serve up, it is a very libertarian take on a particular issue, but it just turns out that in traditional politics, when it comes to your health and your body, many people, whether left or right, are indignant at the loss of autonomy that they suffer as a result of a lot of decisions that are made within the healthcare system. So I think it does a nice job of speaking to a broad audience.
Well, thank you.
And one of the ways, Jeff, that you've sort of opened my eyes when it comes to these issues is by focusing on the use and effects of the government's power to require prescriptions, where it is actually probably the left, the political left, that has pushed for deregulation more than the political right has. And I'm thinking about the experience with emergency contraception and daily use oral contraceptives as well. Can you talk about that history?
Well, well, the way I actually started thinking about that was I was thinking about, I was starting to tell you this before we got underway. In an ideal world, you could be able to purchase currently illicit drugs pretty much along the same model that we use for alcohol. So, it would be, you could have age restrictions, use on public streets, all those kind of things. But, when I go into a store to buy an alcoholic beverage, it says on the label what percent alcohol, let's say, and it never occurs to me they're lying to me or that it's laced with fentanyl because it's legal and it's regulated and there are liability laws. So we should do that with all the currently illegal drugs. But then I thought, well, wait a minute, that would create this weird situation where I need a prescription for hydrocodone, but I don't need a prescription for heroin. I could just go into a store and buy it. And that's what got me thinking about the whole issue of this government requirement of prescriptions, because there was that kind of cognitive dissonance here. And so that's where and then as I researched it, and you joined me in writing a white paper on this, it became clear that actually it was only as recently as 1951 that the government monopolized that. That used to be something that was the pharmaceutical companies would decide, based upon their concerns if the drug that they're nowadays, by the way, they would make this decision a lot because the drugs are much more sophisticated now. But if they thought there's a good chance that the customer will not use it the way they wanted them to use it, and then something bad will happen, and then their reputation will get destroyed and they'll get sued. So they would just stipulate to the pharmacist, don't sell our product to anyone without a prescription. And I have no problem with that at all. That's contractual arrangements, voluntary transactions. So that's the way things were done. In today's world, if we went back to that, the overwhelming majority of prescription meds would remain prescription meds. I don't think the makers of chemotherapeutic agents are going to want to have their products purchased over the counter and risk getting sued over that. But on a lot of the everyday products, the more like birth control pills, which despite for the fact that for the last 20 plus years, the American College of OBGYNs has been saying, you shouldn't have to come to us and get a prescription. This should be over the counter. There's a whole host of medications like that. They would be over the counter.
How would it work for antibiotics from your perspective?
I mentioned that in the book, and that's an exception because I do talk maybe not
a little
as much
bit.
as you wanted me to.
No. So break it down because I
But
think
I
this is a
talked
really
about
important one for
externalities.
externalities.
Yeah, there's a couple of issues like that. So, for example, and it probably doesn't apply to all antibiotics, but a lot of them. But antibiotics, of course, kill off a lot of other bacteria besides the one that you're taking them for. And overuse of them, liberal use of them, could result in altering the ecosystem. And the bacteria evolve very quickly, so it could evolve new strains that are resistant to the antibiotic. We're all familiar with those kind of things. Probably everyone who's had a skin infection has been to a doctor, and they've heard about what they call MRSA, methicillin-resistant staph aureus. But there are a whole bunch of drugs that have developed resistance. So if you're just starting to pop antibiotics because you just think it's a good idea, which you have a right to do, but when it comes to antibiotics, you actually might be endangering everybody else around you by helping to develop resistant strains so that when they get infected, they got a problem because no antibiotic works. So I could see a case, and there are some antibiotics that are more kind of focused, like, for example, for some that we use to treat urinary tract infections, just get excreted through the urine and only affect the bacteria in the urine. But as a matter of principle, I could see antibiotics requiring prescription. There are several countries in Latin America where there are no prescription requirements except for antibiotics.
Yep.
And that's okay with me.
Yeah, I wholeheartedly agree with that, and that's part of why I wanted to raise it, which is to say it's an interesting example where you really see the externality at play in a case like that, and it's probably the best example within drugs for prescriptions, right, for a need to understand the externality. But if you take that and say, I mean, a lot of people have made this argument with respect to cocaine or other drugs where the externality is that people do things like drive or have rage attacks or, et cetera. Can you explain the difference of, kind of why do you see the externality clearly arising in the antibiotic case, whereas it's harder to justify in some of the illicit drug cases?
I don't think it is. Same without, because I just used the alcohol example. So
But what about cocaine?
same thing. I think it's perfectly reasonable to have laws restricting where you could use certain drugs if your use of those drugs puts
Other people
other
at risk.
people in danger. Same thing with alcohol, laws against driving while under the influence. I think that's reasonable. I wouldn't push back on that.
Yep. So it's about context in that case
Yeah,
rather than,
yeah.
yeah, fair.
Same thing, by the way, with you didn't bring this up, but it comes to mind, vaccination. So as a general rule, I don't think people should be forced to get vaccinated because even if I think, and I am not anti-vax, I'm pro-vax, believe me, but it's your body, and if you don't want to have somebody stick a needle in your body and inject you with something, that's your right. On the other hand, there can be a libertarian case made, and I have seen it made by some prominent libertarian scholars for mandatory vaccinations in certain situations, but there has to be a high bar. Like if you have a highly contagious, lethal disease, say Ebola or smallpox.
What about measles?
Well, that's one where it's highly contagious. I don't think it should be mandated, but I think if you choose not to, then I think the government has within its authority to isolate you from other people so that you don't spread what you have to others. In
Just
my
as a
opinion,
public health message, I would suggest anybody who's in this audience or of an age that is like this audience to get your measles titers checked.
I would,
As Secretary Kennedy has advised.
and in fact, when I was, this is an aside, when I was my age, you could tell by my age, we didn't have measles vaccine. Everybody in my school got measles except me. And I was actually, because I was young, I was jealous because I was the only one who didn't have
Right.
measles, and I felt like I was left out. So, and then years later, a measles vaccine became available, and I was traveling overseas, and I asked an infectious disease consultant that I work with, I don't think I ever had the measles, should I get vaccinated? And he said, well, if you're telling me that everybody in your school, in your class had measles, then you probably just had a subclinical case, because that's so highly contagious. I'm sure you didn't escape it, but just the same, it's not going to hurt. Why don't you get yourself vaccinated before you go on in a closed aluminum tube for 8 hours? So I did.
Yeah.
Okay, so if you've got a question here in the audience, raise your hand. Someone will be by with a microphone. When you ask your question, please make sure it is a question without too much preface. And you first, sir.
Thank you so much. I'll try to keep the editorializing down to a minimum. First off, I enjoyed both your presentations, and I look forward to reading your book. You talked about government and the information forcing function. Now, I'd be okay with that as long as it's just raw data. Once government starts interpreting that data, I think that's really when we'll run into trouble. And I've seen the CDC just take data and completely manipulate it to get the answer they want, and I've seen the FDA do the same thing. So could you comment on raw data as in information forcing versus information or interpretation of that data?
And if I may augment that question, what if they just send in random zeros and ones and it's not responsive at all to the requirement? What happens then?
Yeah, I mean, I think interpretation, the question is, what do we mean by that, right? If it's making an interpretation to say, this suggests it's not safe, or this suggests it's not efficacious, or if it's rating or doing things like that. That's not just an information forcing function. But I think an information forcing function could have a standard for what kind of information has to be submitted and in what form it has to be submitted, right? So zeros and ones may not satisfy the information forcing function, whereas, to say that it has to be in a particularly standard form that is understandable. Here's an interesting thing I didn't know until I was writing my last book. I was interviewing the then head of 23andMe, and she told me that in order for them to get a number of claims for 23andMe out to the public, there was a consumer comprehension study that they had to do, where they had to do A/B testing of different kinds of information and then show that consumers could understand the information and submit it in that form when they were providing the information. I wouldn't go that far, but something that said, like, here is a standard form that the information has to be provided in so that it is interpretable by the consumer, right? Rather than burying all the information or putting it in formats that are impossible to interpret, right? Or if it all has to be in a standard form that allows a third party to take that information and compare apples to apples to be able to make the interpretive quality on top of it. The power that a government function would have that a third party certifier wouldn't have is the licensing requirement, right? Which is you cannot put the product on the market until you provide this information, that other entities couldn't have that sort of similar might of power. It's an interesting thought experiment to think, like, could you use government power in that way, the right to market, and treating things as mislabeled by failing to actually have the information provided without the interpretive function, and allow third parties to serve in that interpretive function where they may be better positioned to do that than the government itself.
Would it be possible to separate the interpretive function from just the information providing function? One of the questions we got from the online audience was, actually for you, Professor, what about mission creep? Under that proposal, if the FDA says you have to submit this information, is it also going to specify, not just that it not be random zeros and ones, but that you must have a randomized control trial, or you must have 2 randomized control trials, or are they going to specify that the trials must be of a certain size, or you must achieve statistical significance at a particular level,
Ideally,
or
no,
clinical
right?
significance?
I mean, so if we're doing that, right, then we're back to the same place. But
it can't be a trial with like 2 people in it for
right, but you have
for
to
a new medicine.
you have to submit that it is 2 people, right? And then when you have third parties, right? So part of the problem with third party.
Then everyone would know the government's idea, or the government's information furnishing function is not happening if the trial only has 2 people. So wouldn't that lead to more and more standards that the government would have to impose in order to get the information?
So first, if I say I've done a study and it had 2 people, and here is what I found, right? That gives you the consumer information that you wouldn't otherwise have. If we're imagining a robust world where there's third parties that are taking the interpretive, kind of interpretive stance of providing information to the consumers, without information forcing, it's very difficult for them to do their job. They don't have the power to force information in the same ways. But now you're the consumer and you go to third-party certifier, right, third-party rating system, and you're able to look and see, okay, well, this heart drug is rated very poorly by this third-party certifier because it has only a study with 2 people. This one has a study with 10,000 people. And so if in fact consumers do care, and if there is a market demand for high-quality tested drugs, right, presumably these things work in tandem with each other. So I don't think I would allow mission creep in that way, which is to say you have to have a randomized controlled study, et cetera. But I would say you have to say how many people were in your studies. You have to say what the nature of your studies were. Like, there's lots of things that we could require to say you have to publish all of that information and make it transparent, such that then if there's third-party certifiers, they're able to take that information and do something with it.
Okay, where I would disagree is, first of all, it's still going back to the framing it from presumption of liberty. You're saying the government is saying, I can't have access to that substance unless it's submitted this information to this repository. So there's no difference between that and saying I can't have access to cannabis or a psychedelic until it's submitted
But it's such a minimal thing to literally file and say, I've never done any tests.
Right, there are worse assaults on autonomy. I'm not, but that's
But I
number
mean, I
one.
think you have to balance it, which is to say, is it autonomy enhancing in some ways, which I think it is, and is the minimal effect on autonomy, which is a piece of paper that they have to send into the government to say, I have conducted 0 tests, and I'm not hiding anything. I've literally never tested this on a human or an animal or anything else, nor have I tested its purity. I can't tell you anything about the drug, but I am marketing it. Then me as the consumer, I get to have access to it if I want to, but otherwise I don't have any of that information.
Well, I think, but agencies and entities would develop absent that. In fact, the U.S. Pharmacopoeia, or is it Copia or Copia? I don't know how to pronounce it right, but that evolved. It's still a private organization that evolved in the early 1800s as the first kind of compendium of different medications that were out there, listing whatever information they had available at the time. And actually, my understanding was the impetus for that were pharmacists and physicians wanting to have some sort of a go-to compendium. So the problem I have, again, the fact that it's going to it's much more benign than a lot of other government interventions, but it's still saying that you, an autonomous adult, can't have access to that product until I'm satisfied.
I'm going to just say that that's a framing issue, because it's saying you, autonomous adult, have a right to information, and we are going to ensure that you get that information to be a fully informed adult making choices for yourself.
Well, I don't have a right to the information of somebody who isn't interested in selling me anything.
Right, they would only submit it if they were interested in selling something to you.
But then if a person wants to sell me a product, I want information about this product before I buy it, especially if I'm going to put it in my body. So if that entity doesn't want to give me the information, then, I personally, I can't speak for other autonomous adults, but I'd stay away from it until I knew more. And I'm sure I'm not going to be alone in this, and that would be an incentive for other organizations. By the way, think about some other things. I didn't get into this in the book, but in our health payment system, we've evolved, again, largely due to the medical cartel pushing things in this direction. We have this fee-for-service system, the medical cartels pushed for legislation making it very difficult for integrated healthcare delivery systems like Kaiser Permanente to develop. But it was Kaiser Permanente that discovered the problems with Vioxx first. And so depending on the payment system, that's another way these things can happen, where the incentive there is, if in a prepaid health system like Kaiser Permanente, they don't want to have a lot of adverse reactions that they would wind up being at risk for financially. So they would be doing due diligence as well, and the rest of us could free ride off of that.
I'll go ahead and go now to a question from the audience, and then the online audience, and then we'll take a couple from the live audience. What are your thoughts, Dr. Singer, of people sharing personal medical information on social media if they mention their doctor?
It's an interesting question. I guess it all depends upon what they say about their doctor. Seriously, I mean, if they say something that could be libelous, that's one thing. Otherwise, it's just like anything else. I mean, I don't see anything wrong with saying, I went to Dr. Singer, he was the best surgeon I've ever worked with. I recommend him highly to you. I'm fine with that.
Oh, I can delete all of those questions now. Okay. Rachel, can we get a microphone to Rachel? And then.
Hi, Jeff. One of the interesting points that you make in the book is ways the government has used, regulation and the war on some drugs to target disfavored groups. And you use the example of the quote from a Nixon advisor saying, the groups that we disfavored were the hippies and African Americans, so we went after kind of the drugs that were used in their community. I'm curious if you have other examples in the war on drugs or in other regulation where the government has used it to go after disfavored groups. Quickly, I can't come up with any other examples. The drug example is
quite obvious. I don't know, did either of you have any?
Isn't crack cocaine similar in the significant disproportionate
That-
sentencing between crack and cocaine?
I don't think it was intentional in that case, though, was it?
There have been studies, I think, where some people have said that it was an intentional disparity in sentencing based on racial differences in the use of crack and cocaine. Don't hold me to that. I'm sort of pulling it out of maybe misguided memory, but I think that's one of the other examples that people pull from a lot for a similar kind of war on some drugs.
It can be intentional but hidden. And I know Ken Burns, I think in his documentary about prohibition, was talking about how prohibition often focuses on the drugs of the other.
Sure.
Whether it's if it's Catholics go after alcohol, for example, is one of the examples that he used.
The Ku Klux Klan was advocating for alcohol prohibition prior to its enactment.
Next question, the woman in the third row, please. And then Peter.
Thank you for your presentation. You've spoken a great deal about the deregulation, delicensing. What about the other side of that? The basic individual who's out there trying to make decisions. How is that going to work? Most people know nothing about their bodies. And they go on Google, a stomach ache or asthma or something they think they have. How do you think individuals can make healthcare decisions if you deregulate this? What's on the other side? How are these individuals going to have any kind of education or basis?
Well, no, in a way, I'm not saying it's deregulated. I'm saying it's not a government monopoly in charge. So,
okay, you take away all the licensure of healthcare practitioners. You take away whatever information the government is putting out there. How do people get information? They go to someone who says you need to have surgery and I can do it.
Well, here's an example. I'm a surgeon, and I could, right now, legally, I'm licensed to practice psychiatry or OBGYN. So, but I'm not certified by the American Board of Psychiatry, which is a private certification organization. So the license isn't what protects people. In a way, I'm not saying complete deregulation. I'm talking about no government monopoly regulation, because even with the licensing, there are numerous private certification agencies that certify people as qualified or not. And most hospitals won't let people on their staff who aren't certified, or most malpractice insurance carriers wouldn't cover you for liability insurance, et cetera, like the examples I gave. And so it's real. It's not like it's the wild, wild west. You would have access. You have it right now. You could look up, if just because a person has MD after their name and it says, cosmetic surgery. I know some primary care doctors who started with Botox injections and moved from there to doing cosmetic surgery and had done no surgical training in my hometown. And they were totally allowed to do that because they have a license to practice medicine. So the license isn't what's protecting you, it's the certification.
Hi, Jeff. I saw you on a TV program where you were very complimentary to the European pharmacists. Thank you very much. Would you elaborate on what you were talking about, the fact that we should have it in the United States like Europe, where if you feel a little bad, you go to the pharmacist and say, what do you have I can take without a prescription?
Well, some of that is the classification of prescription versus over-the-counter. So there are a lot of drugs in Europe that are over-the-counter that are prescription only here. That I think that's part of it. But there are several countries in Canada, in Alberta and Ontario, for example, to a lesser extent in Australia, and in the UK for a number of years, most of this century, pharmacists are able to test and prescribe for everyday common routine things. So, and nowadays most graduates of pharmacy school are PharmDs, Doctor of Pharmacy. It's a 6-year program. They know is usually more than we doctors learn in medical school about drug interactions and how they work. So, for example, the states of Colorado, Montana, and Idaho recently passed legislation allowing this. And in Colorado, there are actually advertisements now by Safeway Pharmacy. So wouldn't it be great if, how many times have any of us had a condition where we know exactly what's going to take place? You know, I have a sore throat, I'm going to get this swab test to see if it's strep, and then usually the doctor will prescribe an antibiotic before the test comes back. But I first had to take the whole afternoon off from work, sit in the waiting room for an hour, then make my way into the exam room for another hour, and then the doctor comes in, I know exactly what's going to take place, and get my prescription. Wouldn't it be nice if I could just stop by the local pharmacy on the way home from work, or leave work maybe an hour earlier and get that same service? Also, we know there's a large problem with access to health care these days. Many people aren't close to any doctor, and they can't get in for weeks. There are many more pharmacies than there are medical practices. So if we allowed pharmacists, again, see, I got to reframe that. If the laws stop blocking us patients from asking pharmacists, what do you think, could you diagnose and treat this? If the government stopped obstructing my autonomy in that respect, that would be very helpful.
I think you even brought a Curb Your Enthusiasm episode about this issue to my attention. Yeah, that did air. Okay, so another question. How should we think about medical autonomy for minors? At what age can they make their own medical decisions?
Yeah, that's complicated. I'd be interested to hear your thoughts on that.
You kind of punt in the book.
I did punt intentionally. I mean, I think that's a thorny issue for everybody, regardless of your ideological leanings. When do you define a human as having being able to give informed consent? And right now, it's sort of arbitrary. Right, so it's more of a philosophy of law. The principle is that if you're not an adult, then you don't have a fully formed prefrontal cortex, and you can't give fully informed consent, or if you're cognitively impaired, then it's reasonable for the state to step in, if necessary, as your fiduciary to protect you. But when do we define that? Do you have any thoughts? You're the law professor.
I don't do medical decision-making for minors.
You teach 20-somethings all the time, you can tell us about.
And I don't make medical decisions for them. But what I would say is there are a lot of ways that we could better respect children's autonomy in medical decision-making. There are some things that they don't get to decide, that parents are in the position to decide for them and are supposed to decide for them in a way that is best aligned for their long-term interest. But that doesn't mean that they don't have autonomy and that they shouldn't be given autonomy. Like, for example, if a child who is 10 says, I don't wish in my primary care physician visit to be examined for my private parts by a male primary care physician, by all means, they should have the right to autonomy over their body. Or, for example, my kids, from a very young age, were like, we do not like liquid medicine. It is disgusting. And I was like, well, you're too young, they say, to be able to swallow a pill, but we can practice. If you can swallow a pill, you can have the pill antibiotic instead of the liquid antibiotic. And, starting at like 4 or 5, my kids, well ahead of schedule on swallowing pills, were like, yeah, I'm up for it. and so then the physicians will say, okay, well, they're young, they have to get the liquid. You can say, no, they actually are able to do it and they have made the choice otherwise. These are minor things at the edges. The much more complicated questions arise on, many of the issues that people are grappling with today around vaccination of children, the different surgeries that people are doing on children at ages that are irreversible and very difficult for them to be able to consent to or understand the long-term consequences of, more complicated questions around organ donation and, the right to refuse medical care at a young age when they have cancer. those are well beyond, I think, the scope of this book, but the principle of this book of really arguing for recognizing autonomy, ending with the Hippocratic Oath of asking physicians to really think about, as a core part of what they do, being autonomy affirming for their patients, that should extend to children as well.
And if you want to see the Hippocratic Oath for a Free Society, it's in the book.
Yeah.
So you can, another benefit of buying the book. Now, let me end with a much easier question. Okay. What actions have you seen from Congress or the Trump administration recently that are consistent with or inconsistent with the principles and recommendations in the book?
Thus far, I don't think I've seen many actions in the healthcare space. I can't think of any. Can you? In the healthcare space?
Yeah. So on the one hand, some of the moves toward deregulation might pan out in the long term to be more autonomy and individual rights focused. On the other hand, slowing down approval of things like vaccinations or, the next iteration of the flu shot, I think limits people's access to choices rather than promotes them. And so it's hard to know which way the choices that the current administration goes in terms of aligning with individual liberties or being contrary to individual liberties. I think it's let's wait and see. I think deregulation could be in line with, and slowing approvals of drugs that could be life-saving could be deeply problematic unless their plan is consistent with Dr. Singer, which is to then simply market all of those drugs without standing in the way of them.
In fact, Michael, you blogged about this a week or two ago, about the cuts to the Health and Human Services Department, and you said similarly it depends. In many respects, there's a lot of redundancy, and we don't need all these people doing these things. It depends on where the cuts take place. So if the cuts take place in the personnel that approves drugs and it winds up in slowing the approval process, that's a negative. So,
What do you think about the possibility for mission creep in Secretary Kennedy's proposal to study a potential link, he says, between vaccines and autism? Because there, it seems like what he's saying right now is we're just going to do an information providing function. Do we trust HHS just to provide more information in that area?
well, I think it's been studied to death, and personally, I think it's a distraction. And instead, we could also get into the issue of should the government be funding research or should this be done in the private sector? But in general, I think it's sort of beating a dead horse because this is his hobby horse, and efforts and resources that could be used better are going to kind of repeat the same old thing again. Other areas I have problems with, again, we don't know what's going to happen, but Secretary Kennedy I worry that, I saw him when he was running for president a year over, 2 years ago now. He was in a town hall, and one thing he said in the beginning of the town hall was, medicine's not a priesthood. You should do your own research and make your own decisions. And I was, it spoke to me. In fact, I was writing the book at the time, so I thought this is perfect. But then in the same town hall, he said, we should ban direct-to-consumer advertising by pharmaceutical companies. And I'm thinking, well, wait a minute. So then only the priesthood gets to know the information? I thought, well, how am I going to do my own due diligence? So there's these inconsistencies, and I'm also worried that that we're basically, instead of the government telling you currently what you should eat and what your diet should be, which it shouldn't be in the business of doing anyway, in my opinion, that's personal health, that's not public health, but he would want to replace those dietary guidelines, et cetera, with his preferred set of dietary guidelines. And I would argue that these are things that are personal health issues that we should discuss with our advisors. And once the government, look how great that food pyramid worked out. Once the government gets in the business of telling you we think you should do this, it turns, even if it's explicitly says this is not a mandate, it becomes a de facto mandate.
Professor, anything to add? All right, well then, we are out of time. I want to thank our audiences and our speakers, Dr. Jeffrey Singer and Professor Nita Farahani, and remind everybody that if you're in our live audience, the book is available for sale in the Cato Winter Garden, and we will be having lunch upstairs in the Cato Conference Center. And if you're joining us online, the Jeff's book, Your Body, Your Healthcare, is available for sale at Amazon and at cato.org/books. Thank you, Nita and Jeff.
Thank you so much. You have.